The next session is the Ted King Oration, and the MC for this entire session is Sister Hepsi. I hand over the stage to Sister Hepsi for further proceedings. Over to you. Post the Ted King Oration, we will have the inauguration. We will have our chief guest, Dr. Sailendra Babu, joining us here today. Requesting all of you to please stay with us. The next two sessions are very important, and we would like to have all of you seated for the Ted King Oration and the inauguration. Over to you, Sister Hepsi. Requesting Sister Hepsi to continue the stage proceedings. Continuing the further proceedings is Ms. Sheila Durai.
Good morning, everyone. Science and technology has revolutionized our lives, but it is the memory that transforms us and changes us, and that frames our response. Those who have gone before have planted seeds in a garden. The beauty of that garden is for us not just to enjoy, but to tend with care, to leave a legacy for future generations. One such legacy for the vascular surgical fraternity is that beautiful legacy left behind by Dr. Ted King. Now, may I call the following dignitaries to come on stage for the Ted King Oration of Vicon 2022. Dr. Pinjala Ramakrishna, Dr. Harinder Singh Bedi, Dr. Deepak Singh, Dr. Sanjay Desai, Dr. Gulshan Jit Singh, Dr. Roy Verghese, Dr. Shoyab F. Padaria, Dr. Rahul Jindal. Sorry, Dr. Deepak Selvaraj. I now request Dr. Vimalan, Associate Professor of Vascular Surgery of CMC Vellore, to welcome the gathering.
Good morning, everyone. I'd like to thank you all for coming today. It's the second day of Vicon 2022, and one of the most looked forward part of the program, the Ted King Oration. I'd like to welcome all the dignitaries on the stage. Thank you all for participating in this program. This oration is an important part of VAI because Dr. Ted King was one of the founding international members of VAI, and he's remembered very fondly by everyone. I look forward to hearing from Dr. Pinjala. Thank you, sir, for coming all the way to deliver this oration. I shall now hand over the program to Sister Sheila.
Thank you, Dr. Vimalan. The honor of reading the citation for the Ted King Oration of Vicon 2022 goes to Dr. Shoyab F. Padaria, the past president of VAI. May I now request you, sir, to please read the citation.
Morning, everybody. Welcome to the annual Ted King Oration. So a few words about Dr. Ted King. You know, Ted King was a true friend and a guide of the Venus Association of India. Dr. Ted King was born in 1955 in Indiana, United States. He completed his medical studies and practiced what is called basic family practice, a general practice, what we call in India, for 15 years in Oak City and Chicago. However, from the very beginning, he had a great interest in the specialty of phlebology. And he did some real pioneering work in the field of laser wavelengths, foam sclerotherapy, and compression therapy in the treatment of varicose veins. So much so that in spite of being a family physician, he was a member, a respected member of the American Venous Forum and the American College of Phlebology. In fact, it was due to his work as a family physician, the American College of Phlebology encompassed not only vascular surgeons, general surgeons, cardiologists, dermatologists, but also family physicians, and encouraged them to practice in the field of phlebology. And why is this important? Because you will remember that the Venus Association of India was also formed on a similar basis to encompass people from all fields in this country, from all specialities who have an interest in phlebology, to learn about phlebology and practice it after having gained expertise. Later on, Dr. Ted King joined as the medical director of the vein clinics of North America, in spite of having a busy clinical practice. For those of you who may not be aware, the vein clinics of North America is a group of around 29 clinics in various cities of North America, all of which practice only phlebology. Each clinic has a group of 8 to 10 doctors practicing phlebology, and one of the largest group practice of phlebology in the United States. Now, Dr. Ted King, along with Dr. Mark Malouf and Professor Uhl, were the earliest of the phlebologists from all over the world who attended our earliest YCON conferences. And these three people took it amongst themselves, not only to attend every YCON, but to guide us and teach us the nuances of phlebology as we practice today. In fact, the old-timers amongst us, we fondly remember these people, and especially Ted King. They went out of their way to teach us everything about phlebology. They pointed out our mistakes, pointed us in the right direction, encouraged us to attend various conferences, seminars, workshops all around the world. And that is the reason the VAI today is one of the leading phlebology societies in the world. When I was the president of VAI in 2013, Dr. Ted King honored the Venus Association of India by giving us a special session at the World UIP Congress in Boston. And that was the first time that 8 of the members of our society went as a group to present our Indian work on the international stage. That was a path-breaking event because following that particular conference, the VAA has been represented at almost every single international conference in the world, and the VAA has made a mark for itself, thanks to Dr. Ted King and his pioneering efforts. On a very personal level, Ted King was an extremely humble man, a very quiet individual. At every conference, he would sit at the last bench, the last seat, with his little laptop, listen to all the lectures that we gave, however basic they would be. At the end of the session, or the end of the day, he would approach each one of us individually and point out how we could better ourselves. He would wholeheartedly involve himself in all our activities, and he endeared himself to each and every one he met. Unfortunately, at a young age of 59, he passed away due to cancer in 2015. We lost a good friend, and the VAI lost a mentor and a guiding light. And this oration, the Ted King oration, is a small gesture of remembering a really true friend of the VAI. Thank you.
Thank you, sir. May I now call upon Dr. Rahul Jindal, the past president of VAI, to introduce Dr. Pinjala Ramakrishna. Sorry.
Thank you. Can I have the slides, please? I think Dr. Shoaib Padaria has put it so rightly about him and in such nice way. And, everybody sitting here, he has, touched us in some way, emotionally and, in education way. Dr. Ted King has been to my home 4 times. And, all of us, has been really touched by his presence and always smiling and very calm. Actually, only once I have seen him in slight anger mode in so many years. Dr. Pinjala, as you can see these photographs, he has still not revealed his secrets from last 15 years. Why his hair always remains black, ours are receding. And, just like Anil Kapoor, he always remains young, I think. We all envy him on this. This photograph you can see, it looks same, but actually it's like 14 years apart. So that's what I'm saying. That's the beauty. So, there must be some secret about the research and the things what he do in academics, and it is not publishing it. And, he has been, as all these things you already know about him, academic part. I'm going to tell you about non-academic parts, which you guys may not be knowing about it. So he has published lots of trials, conferences, training courses for nurses, technicians, DNB programs. A lot of laurels for him. On a personal level, he's my senior from PGI. And, I met him first time, you may not remember, sir, in 1998. And I was the senior resident in general surgery. And, introduction to VSI, vascular surgery, should I take vascular surgery or not? And he actually said, yes, it's a very good branch. There were very few people in the surgery. And I actually didn't know anybody in the vascular surgery. And so my senior told me, just go and meet him, and he should be able to guide you. He's last 20 years, you will see him always smiling, very gentle. Any problem in the VI, so we discuss among ourselves and then we go to him. What is your opinion about it? And he's very punctual. And you'll see in all the conferences, if there are 5 people sitting on the front, he will be one of them. So, which is really, speaks a lot, because he really gives the value to the association. And that he deserves. So, and you will see most of the meetings, most of the photographs in the last 10 years, he'll always in the center of the photograph. So I don't know how he manages it, but he always reaches there. I think we all push you in the center and you're always there. And, which is very, very good. So, he was with the governor. And this is, you will see a lot of similar and familiar faces here. And he's always, whenever we are making some new programs, so this was the launching of the venous ulcer registry, so he's always in the forefront. And, man behind a lot of new initiatives which the VI takes. And this is among his friends. He's very calm, on the front seat always. So we are sort of backbenchers. We come off and on, Tarun, all of us, we come up and down. But you will always find him in the front seat. We had a lot of international travel together. So you will see Shoaib, me, Dr. Bedi, we are there always together, and we have a lot of photographs like this, and traveling to different parts of the world, doing meetings and all. And this is another country, as you can see, I'm getting old in last 5 years, but you will find him same. Sir, maybe at the end of the talk, maybe give us at least some secrets about it. So he's really friends of friends, really, and really helped us a lot, all of us. And you'll see in a lot of parties, he will wear very bright colors. Red, green, yellows, and which is really sets him apart in the whole gala dinner. I was trying to find him yesterday with these colors, but I missed it, I think, sir. And the best thing, guys, you should see him dancing. I cannot put in a lot of videos about him. I have a lot of videos. And, dancing on the stage. So, he really puts his dancing shoes on and he can really enjoy. And this is with our friend, Dr. Sunil. We were all very, very close and, really good photographs. And with Tarun here joining us. And this is with all our international friends, Professor Ul, Sergio, and, he is there in the center. You observed? He's always in the center. I don't know how. So, but this is very important point, sir, you must not have observed. Anyway, sir, thank you for accepting to give an oration on Ten King. And, this is an honor for the VI to have you with us. Thank you.
Ladies and gentlemen, can we welcome Dr. Pinjala Ramakrishna as he delivers the Dr. Ted King Oration. Kindly put our hands together and welcome. Delegates, industry, faculty, I request all of you to kindly come to the hall for the Dr. Ted King Oration.
Yeah. Okay, I have to see that now. I pay my respects to Dr. Ted King, who was not only a friend, philosopher, guide, and mentor for many of us in this VSI, WIG. And I'm very touched by his teachings. And most importantly, he came to Hyderabad and he lost his luggage in the airport. So he was remembered for the trouble that he has taken on that day to come to Hyderabad for the Venus Association meeting. He is always humble in his expressions, was listening to all of us, and continued to mentor us in all the difficult situations. I thank him for all that he has done to the Venus Association and to the members of the Venus Association. My talk today would be optimization in venous disease diagnosis and management. Science is expanding. Our understanding of venous disease gradually expanding, and so are the measures and methods that we use to diagnose and treat the disease. Venous disease are never-endingly expanding. So it becomes necessary to optimize the techniques that we use to diagnose, treat venous disease. Venous disease, we all know that it could be acute venous disease, chronic venous disease, acute and chronic venous disease. It can be in one leg or it can be in both legs. So, optimization of diagnosis and management methods, which may be basic or advanced methods, should be done to get the best outcomes and also economically viable measures that are possible in our clinical practice. How to maximize the quality of care relies on the physician using his or her expertise in combination with the best available evidence to determine the right management for an individual patient. However, the explosion of knowledge through print and online journals has made it virtually impossible to read all the published literature related to the particular topic or procedure. So came various guidelines, consent statements, and now we have Venus appropriate use criteria, Venus appropriate AUC, and this is an important step in improving the quality of chronic venous disease care. This has become very important today. What is appropriate use criteria? Appropriate use criteria are additionally intended to help determine if a given patient should receive certain diagnostic test or treatment. AUC use a combination of the best available evidence and expert opinion, but differ from the practice guidelines in two main ways. First, AUC do not require that of the expert panel reach a consensus. Second, AUCs have the ability to address as many permutations of the patient characteristics as desired. The only validated scientific method determining the appropriateness is the RAND UCLA appropriateness method. Dr. Masuda, her co-authors, and the vascular societies who took the high road and addressed both appropriate and inappropriate chronic venous care by producing these AUC. Although the definition of appropriateness can vary from one AUC to the next, Masuda et al. Used the RAND definition appropriateness. An appropriate procedure is one in which the expected health benefit exceeds the expected negative consequences by sufficiently wide margin that the procedure is worth doing exclusive of costs. Therefore, these AUCs should be used to guide the treatments by well-intentioned physicians whose goal is to improve the health of the patients with chronic venous disease. So this is the RAND UCLA appropriateness method where the criteria are derived which can be appropriate, uncertain, or inappropriate. This is now the gold standard in assessing the patients whose appropriateness and inappropriateness. Conclusions. The AAC statements are intended to serve as a guide to the patient care, particularly in areas where high-quality evidence is lacking, to aid clinicians in making day-to-day decisions for common venous interventions. This may also prove useful when applied on a population level, such as practice patterns, and not necessarily to the dictate decision-making for individual cases. As product of collaborative effort, it is hoped that this could be utilized by physicians and multiple stakeholders committed towards improving the patient care and to identify and stimulate the future research projects. For example, if you take and look at the role and appropriateness of radionuclide venography, today we know that radionucleography is not practiced anywhere in the country. But if you look back in 1990s, it was considered to be one of the best methods to diagnose venous thrombosis and pulmonary embolism in one test. But today, the appropriateness is questioned. At the same time, in 2006, our friends from Delhi published the data on radionuclide venogram in diagnosing pulmonary DVT and pulmonary embolism. They screened 1,552 patients, out of which 744 patients showed DVT, and 294 patients, that means 40% had high probability lung scan. So it was an astonishing fact for many of us to know that patients with DVT will have asymptomatic pulmonary embolism. Unless you evaluate, you may not be detecting the pulmonary embolism. But today, if you look at the appropriateness of this test, it is questioned by many of us. CT angio has become gold standard for diagnosis of pulmonary embolism, and it is available in most of the places. What about catheter-directed thrombolysis? Yesterday, we discussed a lot about catheter-directed thrombolysis and its effectiveness. Catheter-directed thrombolysis, in addition to anticoagulation, has been with us as an adjunct for the last 30 years. And the ATTRACT trial, CAVEN trial have given lots of insights into the understanding of catheter-direct thrombolysis in the management of DVT. The conclusion of ATTRACT trial was, among patients with acute proximal deep vein thrombosis, the addition of pharmacomechanical catheter-direct thrombolysis to anticoagulation did not result in a lower risk of post-thrombotic syndrome, but did result in higher risk of major bleeding. That has put off many people, but whereas this was criticized by those who are practicing. And what about Indian data? I'll come to that slide in a second. The thrombolysis anticoagulation has shown 47% post-thrombotic syndrome, whereas simple anticoagulation showed 48% post-thrombotic syndrome. There is not much difference between these two. But if you look at the bleeding, 1.7% major bleeding in the thrombolysis and anticoagulation group, and 0.3% in only anticoagulation group, suggesting that we have to think the appropriateness of the catheter-direct thrombolysis based upon a ATTRACT trial. At the same time, the data from Indian hospitals have shown this technical success rate of 96% with thrombolysis, CDT, and also the patency has been as high as 80% and so on and so forth. So at the end of the day, they said that PCDT is safe and effective. It reduces the occurrence of PTS with preservation of valve competence and vein patency as compared to the anticoagulation alone. So this is encouraging for some of us who would like to continue catheter-direct thrombolysis. But again, we should look at the appropriateness of this in clinical practice. So this paper was published in Indian Journal of Vascular and Endovascular Surgery. And so the need for venoplasty stenting in PCDT group was also looked at. In 2020, appropriate use criteria for chronic lower extremity venous disease were brought out by a multi-society document. We have been discussing all through about the appropriateness of GSV ablation based upon the SEEP grading, short saphenous vein ablation based upon SEEP grading, appropriate. The green one suggests it is appropriate. The brown one shows rarely appropriate. Red one says never appropriate. So for anterior-axillary saphenous vein ablation, what is appropriate? For perforator vein treatment, what is appropriate? For stenting the iliac vein, inferior vena cava, what was appropriate was shown beautifully in this slide. So we need to understand the appropriateness and inappropriateness to recommend a treatment for the patient to say the optimization. In a similar fashion, how appropriate we are in giving thromboprophylaxis in trauma patients, DVT patients. So this paper was published in European Journal of Vascular and Endovascular Surgery by Agarwal group from Vellore. The incidence of VTE was 17.46 per 10,000 admissions. Malignancy was the most common predisposing factor, followed by post-operative status, 30%. The incidence following surgery was 5 per 10,000 operations. General surgery patients had the highest incidence of deep vein thrombosis, DVT, that is 40.3%, while the incidence of orthopedic patients was only 20.1%. It is quite different from what generally is thought and discussed in the Western literature. In Western literature, it is the orthopedic patients who have high incidence of DVT, but it was shown differently in the trial from Indian hospital. Low molecular weight heparin has been increasingly used therapeutically over the years. Pulmonary embolism was seen in 14.9% of the study patients. Mortality in those confirmed pulmonary embolism was 13.5%, which is corresponding with the Vasisth trial, which was done in PGH Chandigarh autopsy trial. So we have conducted similarly a number of trials to identify the risk of thrombosis in our patients. ENDORS, RELIEF, PROVE registries were done by me in the past. What did we learn from ENDORS trial? ENDORS was quoted very often in the literature. The risk of thrombosis in the patients who are admitted to the acute hospital beds was assessed, and the use of thromboprophylaxis was also assessed. The risk was high, continues to be high in all the countries, including India. Every alternate patient in acute critical care bed is at risk of pulmonary thromboembolism, but only 16% surgical patients, 19% medical patients received thromboprophylaxis. That indicates it is inappropriately treated, and we have to improve the understanding of thromboprophylaxis in our Indian patients. SIP classification. Is it appropriately used in clinical practice? Yes, we know that SIP is mainly followed for clinical grading, that is C1, C0, 1, 2, 3, 4, but the remaining parts of SIP are not mentioned in any time by most of the clinicians who are treating venous disease, except for few specialists like VAI members. Very few people other than this document SIP classification in their clinical practice. Appropriate use of diagnostic measures, very important for optimizing the diagnostic measures. So pre-test probability, various scores are available. Compression ultrasonography, D-dimer, duplex scan come under level 1 evidences, whereas CT, MR, conventional angiograms, ventilation perfusion scans come under special advanced investigations. How far we should evaluate the comorbidities in our patients? What is the optimum diagnosis of these, such as cardiac, renal, pulmonary, hepatic, cancers, vasculitis, collagen vascular diseases, undetected trauma, and hospitalization. All these factors increase the risk of thrombosis, but how far we should investigate and diagnose these conditions? We found out that in a trial conducted by us, indicated that the elderly male patients with a high BMI seem to be at high risk of advanced clinical grades of CVI. The impact of comorbid conditions such as diabetes, hypertension, and hypothyroidism on CVA could not reach significance in the present study. So we found out that the comorbidities do have a role to play, but their role has not been found to be significant in the trial conducted by us. What is the appropriate use of anticoagulation? What is optimal use of anticoagulation? So we need to have net clinical benefits. Number needed to be treated, number needed to be harmed should be coinciding, and we should have more number of patients to be treated to get one harmful effect. Less number of patients should be treated to get one benefit. That is what it is. NNTs and NNHs are important to get the net clinical benefit. Anticoagulation, the crucial thing is what is the optimal monitoring, what is the optimum time in therapeutic range, what is the bleeding risk, what is the optimum bleeding risk, what is the duration and what is the optimum duration, and what are about the tests such as TEG. Tests such as thromboelastogram are not appropriate at this time of the clinical status, but in future probably, maybe we will be talking more about thromboelastogram. Currently, the trials that have been done have not been shown to be beneficial in considering thromboprophylaxis based upon thromboelastography. What is the ideal or optimum TTR? 60 to 70% is the ideal TTR time to get the maximum benefit of anticoagulation in our patients to prevent recurrent thromboembolic episodes or pulmonary embolism or sudden death in our patients. We did this trial and found out that those patients who maintained TTRs between 60 and 70 had excellent Villalta scores in the follow-up of the patients. So this paper was published by our group and said that optimum INR values are very important. Optimization of warfarin dose. It is also an important thing, but very few people are doing research in this angle. Pharmacogenomics. Is there any role of pharmacogenomics in deciding the dose, warfarin dose in our patients? I think this trial was also done by us and found out that certainly they are helpful, but appropriateness of this test at this moment is questionable. Very few centers are able to do pharmacogenomics to decide the pharmacological dose of warfarin in the treatment of our patients with anticoagulation. Optimal therapy for varicose veins. Primary varicose veins, secondary varicose veins, post-thrombotic varicose veins, recurrent varicose veins, residual varicose veins, what is the optimum that one would like to do is a question, I think, where we need a lot of research further to understand what is the optimum level of treatment in such different types of patients, or a combination. What is the optimum documentation of venous mapping? I think very few centers are mapping the veins adequately to understand the pathological process that is happening in the superficial system, GSV, above knee, below knee, short saphenous system, perforated system. Proper mapping techniques should be done to get the optimum results and benefits in treating our patients. Assessment of the treatment, assessment of response to the treatment. How to assess the optimal response to the treatment? The best way to assess the response to treatment is VCSS scores. I think this is also underutilized by our team members who are practicing venous surgeries and venous interventions. So for example, if you see this upper diagram, the venous clinical severity score in this is 8, and after treatment it has become 4. So this is the best way to document the assessment outcomes in treating the patients. As determined by the venous clinical severity score, treatment saphenous vein reflux with endovenous radiofrequency ablation results in clinical improvement by symptoms and aids in the healing of venous ulcers. Age, female sex, and tumescent volume are associated with high success rate of occlusion. They found out that the venous clinical severity score to excellent standalone tool for assessing the outcome after a saphenous vein radiofrequency ablation. So the practice of venous clinical severity assessment before and after interventions becomes essential, and it is still underutilized. We need to improve it to get the maximum and optimum utilization. What about SEEP classification? SEEP classification and its recent revision are primarily descriptive tools used to classify and categorize the patients on presentation. The SEEP classification is relatively static, however, changing little over time, and is a poor method to assess the usefulness of an intervention. So that is why many papers have shown combination of SEEP classification and venous clinical severity score is the way to go forward in assessing the patients of venous disease before and after treatment with various methods that we give the patient. Now coming to the optimization of the venous disease assessment treatment, endovenous therapies, thrombolysis plus plasty, thrombolysis plus plasty plus stenting, thrombolysis plus plasty plus stenting plus splinter deployment. Then what is the optimum endovascular therapy? I think we need to assess each individual patient to decide how much is the optimum in this patient, whereas a group will say that I don't want to put a stent, one group would say I would not like to give a lysis. So there are always arguments and discussions, like we have seen yesterday, wonderful discussions that have taken place. Similarly, anticoagulation, when to give, how much dose to give, how long we have to give is also important in combination with the therapeutic interventions that we follow. What is the role of DOACs? There are unmet needs with the oral anticoagulants. Those unmet needs are met by the DOACs. So there is a role, and optimum utilization of DOACs should be done in the given patient. Thromboprophylaxis, primary thromboprophylaxis, secondary thromboprophylaxis. So is there any role for routine thromboprophylaxis justified in Indian patients sustaining major orthopedic trauma? The answer to this is yes, because the incidence of VTE among thromboprophylaxis receiving group was found to be as low as 8%, whereas it was much higher, 14.49%, in those who are not receiving any form of prophylaxis. Indian patients have definite risk of venous thromboembolism after major orthopedic trauma, and thromboprophylaxis, either by chemical or mechanical methods, seems to be justified in them. I think this is appropriate to consider in all major orthopedic trauma patients, thromboprophylaxis as a priority. And to improve the outcomes of these patients, we should recommend thromboprophylaxis, and that seems to be appropriate. What about cancer patients? In a similar way, in cancer patients also, it is essential to understand the risk of bleeding, and appropriateness of anticoagulation should be considered. Current trends in the duration of anticoagulant therapy is discussed extensively by a number of trials as you can see here mentioned, and Einstein extension, Amplify extension, Hokusai extension. All these trials have also been helpful in deciding the extent of anticoagulation in current practice. Optimum diagnosis of lipodermatosclerosis. We don't have guidelines to assess the grades of various types of lipodermatosclerosis. We only say about plus or minus lipodermatosclerosis, and what is the optimum treatment or what should be the duration of treatment for lipodermatosclerosis is also not established today in the clinical practice. Compression therapy, a lot has been discussed yesterday about compression therapy, long stretch bandages, short stretch bandages, non-stretch bandages, pressure graded stockings, and also the wraps. I think extensively discussed by Dr. Rahul Jindal about the wraps and their usage should be optimized in clinical practice to get the best outcomes. The interface pressure measurement is also not practiced by many of us, and it should give the optimum results of compression therapy if you practice that with PICO. What is the optimum therapy in varicose veins? I think now many patients are being given various combinations of therapies, such as endovenous thermal ablation plus foam sclerotherapy plus such as LAFOS, or combination of phlebectomy, surgical therapies. I think what is the optimum we should decide. I think this morning also we discussed, yesterday we discussed perforator, how to manage the perforators. In asymptomatic C12 patients, we should not consider dealing with perforators as one of the guidelines that was brought out. In venous ulcers, I think once again, combination of various methodologies will give the optimum results, such as medical therapies, interventions, surgical therapies, and compression therapies. Optimum utilization of the diagnostic measures and the therapeutic measures in venous disease will bring economic relief to the patients and the hospitals, and the resource utilization is going to be better in clinical practice. So at the end, if you diagnose and manage venous disease effectively, adequately, optimally, the sick leaves of the patients will come down, the loss of working hours will come down, and the economic status of the patient and patient family will be much better off. Ladies and gentlemen, I tried to give the importance of optimization of the science that has progressed in understanding the disease, chronic venous disease, diagnosis and management. And to get the best results of our treatments, we should know how to assess the disease, and we should also know how to utilize the resources optimally to get the best and optimal outcomes. Thank you very much.
Ladies and gentlemen, let's rise, put our hands together and give a standing ovation to Dr. Pinjala Ramakrishna. It's now time to honor him, and may I call upon Dr. Harinder Singh Bedi, the President of VAI, to present the plaque of honor to Dr. Pinjala Ramakrishna. Thank you, sir. I now call upon Dr. Roy Verghese, Chairman of the Governing Council, VAI, to present the medal and the citation to Dr. Pinjala Ramakrishna. Thank you, sir. Dr. Gulshanjit Singh, Treasurer, VAI, will now present the shawl and the certificate. Remove the shawl. Thank you, sir. Dr. Deepak Selvaraj, Vice President VAI, Deputy Director of CMC Vellore, will now propose the oath of thanks.
On behalf of the governing body and the governing council, I wish to thank all of you who have come for this annual conference. The TED King Oration is a very important part of our conference. I thank you all for coming and attending this oration.